Welcome to Behind the Research, a special segment of the PT Meal podcast where we digest the science behind physical therapy practice. In this series, we talk to authors of published research from the Philippine Journal of Physical Therapy to explore the data, the methods, and the real-world impact of their work. I'm your host, Johan De La Paz, and together, let's bridge the gap between evidence and clinical care and find meaning beyond the pages.
Welcome back to PT Meal Podcast, a buffet of play, therapies, movement, exercises, activities, and leisure, all packed in a hearty conversation about the physical therapy profession and practice with a Filipino flavor. I am your host, Johan De La Paz. Welcome to the banquet. So today, we're back in Behind the Research, diving deeper into published works from the Philippine Journal of Physical Therapy and exploring how its findings can shape our practice. This segment is in partnership with the Philippine Journal of Physical Therapy and the official journal of the Philippine Physical Therapy Association. So I'm pleased to welcome back to the podcast and first time in Behind the Research, the principal author of this today's research, Dr. Lily Bautista, to talk about their research entitled A Retrospective Survey of Joint Mobilization Utilization during clinical internship of Silliman University Physical Therapy Alumni. Welcome to Behind the Research, Dr. Lee. Hello po.
Hello. Good morning from the Philippines. So, Johan, thank you for the invitation and the opportunity to discuss a bit about our research. This is actually a research that we did during COVID.
Oh, wow.
So it was kind of interesting that we got more time at that time. So we were kind of discussing it for a while, but then I guess the COVID season kind of gave us the opportunity to actually accomplish the research.
That's good. At least there's something good that came out of COVID.
Yes.
So to really begin our discussion, for those who are not familiar with the research yet, who hasn't heard or read about it yet, could you give us a quick overview of what the research is and what's it's all about?
Okay, just more of a bit of a personal background. When we started Payom, we really had a lot of people telling us all of these challenges and barriers with regards to use of joint manipulation or joint mobilization. And but if you look at the Philippine context with regards to research, there's really nothing out there. So I'm really very happy that they finally started that Philippine PT journal, because now I think it provides a lot of avenue for Filipino researchers, because before we really would um would publish in multidisciplinary journals, and I think the readability is not as much because we don't see it, versus now we have like a journal that really focuses on that. So we all this time we're always hearing challenges and barriers, but really there was nothing to support that. And of course, if it's not written, they were not sure if they're just kind of hearsay or maybe is it true. So that's really what started it, and it's actually a second research already, Sir Johan. The first research was published at the Recoletos Multidisciplinary Journal, which again, as I've said, at that time there was no PhilPTJ yet, so we published it at a multidisciplinary one. So this is already the second one that is related to joint manip or joint mobilization. That first one, the respondents were actually administrators of the schools of the Philippines. So it was a very good research as well, because we were trying to find out exactly, number one, are they being taught in Philippine physical therapy schools? And then after we finished that research, this one came about. So that first research indicated that it is being taught in schools, but primarily the extremities. So very limited on the spine. So then the next thing we did is this one, which is now in the context of the students. We did attempt, to be honest, to do a wider scope of respondents, but it was difficult to get approval from the other schools because of all of their ethical limitations and such. So then we ended up doing only Silliman University interns.
But it's still good since the span of the alumni is from 2018 2020. So that's 2018, 19, and 20, three batches, right?
Yes.
Mhm.
three batches. And we chose that because, again, when we were doing this was during COVID times. And so we thought that there's going to be limitation with the application of
Uh,
the actual skill. So that's why we went backwards. So we went like 3 years below 2020,
mhm.
because that was the time that they all canceled internship and such like that. So it was actually pretty good. We exceeded, I think, based on, sorry, I don't have it top of my head. I think it's Slovin's formula. We used it. It was only 94, but we ended up with 97. But
Mhm.
I think we removed one because there was like a problem with the response. So we ended up with like 96. So it was a pretty good number.
Mhm. Aside from it's being COVID, what's the other like biggest challenge encountered while gathering data during that time?
Um, Actually, it was well, the biggest challenge was making people like fill it out
Uh-huh.
because like before that time we were so used to paper, pen and paper. So like when we were doing research before, you disseminate the paper and then you put it manually in Excel.
Mhm. Right.
But that was the time that we had to start using Google Forms. I
Mhm.
know it's been in the market for a long time, but you know how we were in the Philippines, we were behind. So then we kind of like initiated it. We started with that, and it was challenging because like a lot of people really would say it would take so long, but we're like, no, it doesn't really take a long time. So it took a while, to be honest, for us to really go through the process of like gathering data. So we had to do individual, like we had to send individual messages. Hey, can you please like fill this out? So that was the major challenge, but it was just a questionnaire. So it was really easy, but we did have, I think it took us longer to do the reliability study. So we did a reliability because it was created questionnaire was created only by the researchers, so
Mhm.
that took a while.
Uh,
um yeah, before we were able to disseminate to the actual participants.
so let's go to the findings of your study. You found that the joint mobilization was often performed in outpatient settings, and rarely in inpatient or home health. Why do you think that result existed?
We really did not ask the whys. But personally speaking, I really think that because in the home health, it's a cultural thing that we just do mostly, like even inpatient, right? Like meaning we mostly do gait training, bed mobility, transfers.
Mhm.
But we forget that many of our patients, even let's say our low back pain patients, our shoulder patient, even stroke, like that's what we have been kind of like promoting with our students now. Like, you know, when you have a stroke, you have like musculoskeletal issues, you have like shoulder subluxation, you have like stiffness of the hamstring. So there's really value to manual intervention, even for your neuro cases. I think, again, because we think it's neuro or because we think it's just geriatric and we just want to make them walk, we just make them walk without really like looking at the actual limitation. Like, why is it that people cannot walk? Why is it that people cannot reach? So then it has to go back to the, to the basics, gotta go back to the drawing board. Like, and for you to increase like mobility of the shoulder, you cannot just make them reach. You're gonna have to kind of like treat it as if it's a shoulder limitation. So which I hope that's why I kind of read through this research again, and that's why I'm like, I wonder if the students will have a different response now, because since this research we really have improved, and I was already the director at the time here at the department, so I really made a lot of changes.
Mhm.
Based on the responses, they really did not feel comfortable on the spine. So I actually took over teaching of the spine, and then see if that would kind of like improve now the level of competency of the students. So it would be
Mhm.
interesting to do a follow-up research with similar questions and different set of population.
Right,
So
right. I remember when I was in PT school, we when we talk about joint mobilization, it's always, you're right, the extremities and not on the spine. And they say that mobilization, manipulation of the spine would be something advanced. So it's like it's not included into the basic competency of an entry level physical therapist. So it's interesting to find out how the new batches of physical therapy graduates would respond to this and how they practice it. It's quite interesting to know about them. Um, and I like what you said that talking about stroke and uh, physical therapists are focusing on neuro because they're stroke, but they forget that these persons or people would have joints and muscles, and that is you have to attend to that as well. Similarly to when people look at musculoskeletal problems, they forget that there are nerves. So we kind of compartmentalize issues to neuro and muscular, they have to really look at the person and all of those things that affect them. So we the what do you call this? The tool that you had was self-reported, self-report competency was high for shoulder and lowest for the spine. Is this because the curriculum was new on teaching the manipulations and mobilization on the spine, or were there any other factors that might have contributed to this result?
Actually, because if you look at the participants, that was in 2018, 2019, 2020.
Yes.
That was barely when we started. This is for Silliman University, so I'm not I don't know about the other schools. That was barely the time that we started with the new curriculum, wherein because before, like with your curriculum, there was just therapeutic exercise, wherein you guys were taught the mobilization for the upper and lower extremity. But now, with the CMO 55, they actually have suggestions of orthopedic rheumatology and sports. So at Silliman University, we divided it. We divide we call it ORS, upper, lower, and spine. So it allowed us to give more time for improving the competency and maybe the theoretical background of our students. So some of these people that responded, although they belong to the new curriculum, we still had to carry over all of the learning, all of the previous culture. So it was barely after COVID that we started really sending our faculty members for specialization in upper extremity, lower extremity, spine. So a lot of them now at our faculty level are more familiar with higher level of learning, because a lot of these factors, I think it boils down also to the competency of the faculty member to teach. So as I mentioned to you on the very first research, that was the primary response of the school administrators. Like they were not really teaching much of the spine because no one in their faculty lineup could teach it. So then they focus on the upper and the lower extremity, primarily the upper extremity and the shoulder. People love the shoulder, I think, because it's so easy to manipulate. So I think even teachers get comfortable with it fairly quickly with regards to your basic concave convex rule versus for example, your hip. It's so big, so that is the primary challenge that most faculty would say, that they don't know how to manipulate it. But we're like, well, that's why you have to attend additional training, because there are strategies that you can really use, to kind of improve your body mechanics or lessen the load on your shoulder or something like that. And then the knee, they just mainly talk about the tibiofemoral, not really talking about, not considering the other components, the adjunct rotations and such like that. So, but those are kind of I think it's improving, because I think I hope that we have created greater awareness for the importance of some of these additional tools that a physical therapist can use.
So this is a question for later, but since you've already touched on certifications of um, the faculty and sharing that knowledge to the students, do you think that certification in this techniques should entry level physical therapists finish with certifications, or it's okay for them to graduate without any certification and just continue doing further studies as they graduate, as they earn their licenses?
Um, that is another response that based on the challenge, one of the, I think the like additional qualitative data that we collected from this research, one of the response was that they thought that you needed a certification for you to
Mhm.
perform it. And even the CIs were thinking they needed certification. But even as old as our 1960 law, it even says there that the basic competency of a graduate requires manipulation. So you don't necessarily really need, that was in the 60s, right? So it was already included in the definition of the competency of a physical therapist. So it's not really required that you have a certification before you can perform it. That's why students are even being taught the thing in school.
Mhm.
And there is nothing in there that also excludes spinal manipulation,
Mhm,
right? There's nothing there. It just says joint manipulation,
mhm,
joint mobilization. Um, and as far as I really think it kind of boils down to the competency of the teaching faculty, and not competency, but maybe the ability to teach it, because you have to be very comfortable also to teach it. So I think that is when all the certification come into play, because the greater the lifelong the learning, like after you, let's say you're a teacher and you graduated from PT school and you have 2 to 3 years of experience. So I think if people attend additional courses, additional lifelong learning activities, that doesn't only improve the competency or the skill, but
mhm,
it improves the confidence level
mhm,
of a person, because in your mind you really know more than the average Joe or Jane.
mhm,
So then you would be able to teach it better because you believe that you have like the ability to teach it better because you have attended all these additional courses. So I think if one is going to be teaching and going to be a mentor,
mhm,
I do highly suggest a certification course. However, if you are just going to, let's say, be a clinician, starting clinician, treat patients, um, not necessarily you will need a certification. I think you just attend your courses and then practice, because most of these things are already taught in school. Like,
mhm.
right, as
Yeah,
early
I
as
agree.
like level 2 student, you're already being taught like your concave convex rule for the shoulder, for the elbow, for the wrist. But if people don't use it, then they won't really, number one, they really won't know the effect it would have on their patients. They
Mhm,
would really start justifying amongst themselves that exercise should be good enough. But how do you know that exercise is good enough if you haven't really tried the other tools? So, I mean, that's why these kind of like things are adjunct to care, but of course, it needs to be applied. It needs to be tried before you can really make your own decision, like if it's going to work or not for your patients.
I agree with that. But what you said that we are taught in school the basic mobilizations, and those lessons that I learned from school are the same lessons that I use right now. And then I attended like some courses that are like specific to my population. Like if I want to refresh or know more about current trends on shoulder mobilization, then I'll attend course for mobilization. If I need to learn more about low back or hip mobilization, then I'll attend that. But most of what I'm doing right now in terms of mobilization, specifically shoulder, since most of my population are like shoulder issues, these are the things that I've learned in school and they're working. And then once they stop working, that's when I start to look for avenues to learn more. So
Yes,
I
yes.
totally agree what you said about that.
Yeah,
Um,
and to add to that, Sir Johan, like a lot of these certifications, like even let's not just even talk about MSK, pediatric, neuro, BOBAC, like those are things they were already taught in school. They're not really new. The
mhm,
only thing that we will learn new, right, like that's not in school, are the ones that are probably not PT related. The ones taught by osteopath, like the ones taught by like new tools. Which there's nothing wrong with that. But if we're just talking about plain and simple physical therapy tools, they should have been tackled in school already. However, okay, I really highly encourage clinicians to still attend courses, even if I'm saying they should already be taught in school. Why is that? Because if you're a student, your level of understanding is still very basic.
right.
Once you start teach but once you start treating patients, once you start seeing the true disease joints, like shoulder dysfunction, you have a better background of like, oh, okay, that is what it means by a capsular restriction. Oh, that is how it feels. So then all of these theoretical foundations you have learned in school, you'll be able to apply it better because you now have a better understanding of the actual pathology versus just memorizing it from a book or treating your classmate or your partner, because they're normally kind of like pretty okay joints. So then you won't have an ability to really do a very good inferior glide, or a very good posterior glide, because they're pretty normal joints. Versus like, if you already started practicing and you now have felt how these joints feel,
Mhm,
I think when you attend the course set, it really enhances. So I use the word enhancement because like it really will make you open your eyes up like, oh yeah, it's not new,
mhm.
but you feel like you learned something new.
You
So
understand it
because you
better, you
understood
appreciate.
it better.
Correct.
Yeah,
Yeah.
I appreciate it better.
Yeah. Like when I attended a course here, it's not new, but the explanation was better in my ears, and I was able to appreciate more of it because I've handled patients that what the mentor or the speaker was talking about, and they're like, oh, I can remember a patient like that. So you learn to appreciate the learnings that you've had from school, and then what you're hearing again from the courses that you're attending. So yeah, I do get that. One of the going back to the study, one of the many interns identified that there's a lack of orders from physicians since we're in the Philippines, we're still relying on physician referrals as a major barrier. What are your thoughts on that? Do we need to share to physicians what mobilization is for, or should it be coming from us to tell the physician, oh, I'm going to try this? So, is that okay?
Okay. Yeah, so I think this is just like it validated what clinicians are telling us, right? That the doctors are not ordering it. Um, the next part of the research that we're kind of like hopefully looking at are responses maybe from the actual physicians, referring physicians, because like after this research I really started talking to some of the physiatrists and
Mhm.
other doctors, orthopedic doctors, on why they don't refer for joint mobilization and manipulation. And across the board, so Johan, the response is like, well, nobody knows how to do it.
Yeah.
So I'm like, so I think with your question, I would be more inclined to choose the second answer, wherein the clinician should discuss with the doctor, like, doctor, I really believe that this patient would benefit from, like, this tool, from this mobilization or manipulation. And then you just justify why do you believe certain things. And I think that again boils down to the level of expertise or confidence of the clinician to
Mhm.
justify why they're recommending such, because some of our clinicians unfortunately have gotten used to just following the order, so it's a checklist.
Yeah.
So which again we have been like, hopefully with the new batch of people that we have, the K to 12, there's really a lot of focus on critical thinking, independence, autonomy. So
Mhm.
hopefully they'll be able to really communicate with the doctor as equals. That
Mhm.
is what we want to happen. Doctors are they are doctors, but they're also just part of the allied health team. So we really should be able to talk with them in a collaborative manner rather than an inferior, or not, rather than a superior type of communication. So I think with our we have like, even at Silliman, we have like 200 something units of courses. So surely we would have learned many things with those number of units that we learned in school, and then to add all of the lifelong learning activities that the clinician would attend after graduation. So I think it kind of boils down to the clinician being able to discuss
Mhm.
with the doctors the importance of the need, because I really do not believe that any doctor, regardless of what they believe in, I don't think there would be one that would say no if they believe that it would be helpful to their patients. So we have to be able to justify, and I still kind of believe in that regardless of who the person is, what kind of doctor they are, they almost always would want what's best for their patient. So they would not say no to something if they think it would help their patients.
Right. Something I learned here is that you medical doctors, physical therapists, nurses, OTs, we're co-workers. So they're not medical doctors are not our bosses in the greater scheme of healthcare. We're all working together. We're co-workers in the sense that we're working together for the benefit of the patient, and whatever the bit we think
Exactly.
the patient would benefit from, we should be talking about that. You're correct. We have to be, more collaborative. The study also highlighted some low confidence and lack of opportunities as barriers. So it does make sense. Like if you're learning something from school, but there's no opportunity to practice that, then where's the continuation? Where are you going to gain your confidence and skill? How do you see that affecting graduates, the respondents, and also you know other graduates? that might be encountering this?
Yeah, unfortunately, yes, it will domino, because even if we teach it in school and then they go to the centers and the centers don't make them apply it or use it, then by the time they graduate, they would have forgotten already. They would forget. And a lot of the new clinicians that we have in the past, of course, had limitation also with their learning in their school. So we are now banking on, me personally. This is a personal personal observation. I am banking on the idea of the future,
Mhm.
because our future graduates now will be the future clinical instructors. So if we continue to emphasize with these clinical instructors the value of, um, other things, other type of treatment besides, like, just the one thing that we've known, like exercise and modalities. That's all we've known in the Philippines. There are many other things out there now. So we're kind of hoping that with this new, incoming clinical instructors, they would be, the catalyst for change. Because even if, like say for example, in a clinic, you have people there who are already a little bit on the senior level, like not senior by age, like meaning senior therapists in their 40s and their 50s. They see some of these young ones performing things and treating patients and making patients better in 3 to 6 visits versus the usual 8 to 20. Then I'm sure that yes, hopefully they can now, uh, encourage, like, some of the more senior therapists to really enhance their learning some more, that there are new things out there. We have progressed so much. We should not be living still in the modality and exercise space, worse modality only, right? So because we still have centers that are modality biased, they give exercises for 10, 15 minutes. However, okay, so we do, the way we do our internship program, so Joanne, is like we do, try to vary it. We have centers that are mainly modality bias. We have centers that are mainly like, manual therapy bias. We have centers that are exercise bias, because we wanted the students to see
Mhm.
what works. So, and now I can really say, like, I've talked to many of our alumni. So we do have the luxury of that. We're able to, kind of communicate with our alumni. So what do you guys think? No? So what is your treatment of choice? And to be honest with you, many of them like go back to manual therapy and exercise. That is what they have been focusing on. That's why many of our alumni have been, attending our certification courses with, OMPTSG. OMPTSG is the, sole provider that's accredited by PAYOM to offer these certification courses. Um, and uh, it's actually kind of like coming back, because we wanted them to see, okay, now you've done modalities, now you've done exercise and modalities, now you've done hot pack, ultrasound, and whatever. So what works for you?
Mhm.
So it kind of like, now they're able to decide for themselves. So we do just need to do our best to, offer them all of the things that are evidence based, that's out there, that's being used out there, and, make them realize that there are many other treatments that are new now, except, aside from the ones that we're used to, like for the past 30 years. So.
Yeah, I like that they're exposed to those different types of practices like that. You know, the what do you call what we've done before to exercise centric to manual therapy, heavy practices, and then at least they get to compare, and what they feel comfortable of doing. Hopefully, the exercise and manual therapy and not the modalities based. Have to get away from that. Now I just remembered a new facility when you mentioned about modality based practices with HEP like 10 minutes or just like homework. And then, yeah. So, and then they're trying to say that it's physical therapy because there's exercise, but it's homework. I don't like that. So,
I know exactly. So, but again, because we are in the Philippine setting, because I've been asked, like, so if you believe this, so why are you doing that? Like, because I'm still the coordinator for internship. I'm like, because I want them to decide for themselves,
mhm,
because, I know in the past we tell people, okay, this is evidence. We're so very, um kind of black and white about things. I'm not that kind of person. I don't, I have a lot of gray areas,
mhm,
because I want people to figure it out themselves, because once they figure it out, they will believe it more because it came from them.
Right.
So instead of me telling them, no, don't use modalities, do this. So I still kind of believe in like, okay, you go try it. So you go, I'm not saying anything against modality, but I'm saying like, you try putting them on hot pack, you try putting them on, I mean, you try even all of these, what is that? This Tekar thing that's kind of, I don't even know what it is, but like it's all coming out and it's so popular. I'm like, you go for it, you go try it. I have an alumni that was asking me like, what about like, should I buy? Should I buy? No, like I have no idea if you should buy because I don't even know what it does. So, but it's going to be up to you. Like, if you will kind of spend your millions on that, like go for it if you feel that it's going to be valuable for your patients. So, and now what's interesting with our study is that Manila really did a lot of manual intervention, and I thought Cebu would do, but Cebu was the lowest. We sent our interns to four areas: Cebu, Bacolod, Manila, and Negros Oriental.
So is that
So Manila is still number one. Yeah, but maybe because that's where we have all of our specialization in Manila. That's where you have all of like the higher level of learning. So, but number two is Negros Oriental. So then I was kind of excited because maybe I'm kind of like, maybe there's a change that we're bringing here, like, so because we're very active. Payom has always like in relationship with like Negros Oriental PT. So it ended up being the second wherein the interns get to practice their manual therapy skills. So that's, I'm like, that's kind of a nice finding. So, but then I was surprised about Bacolod being over Cebu because Cebu would be more metropolitan and bigger than Bacolod. But it ended up like Cebu had a very, very low utilization of manual therapy. So,
It would be interesting if you keep on doing this as as years go by, see if there's any difference. Like 3 years and then another 3 years later on, 3 years later on. It would be interesting. I would try to track that and see what the difference would be. Even trying to
I know
track
that
your respondents
that's
now.
what I was like, yeah, that's what I was like, kind of thinking maybe use the same kind of questionnaire with a little bit of revision and
Uh,
then see if the responses would be different now. Like,
mhm,
because now we're graduating many people
mhm.
from past COVID. So it would be interesting. Maybe in the next 2 to 3 years, that would be a good thing to look at because that would have been um, maybe 7, 8 years from the time of this research. So then we would see already that the change, if there is a change, and then maybe do a comparative analysis of the responses. So that would be very nice to see.
Right, right. Yeah. So we're almost close to our end of our conversation. I just wanted to ask us a couple of questions more, just to wrap things up. So what advice would you give to current PT students and interns right now who feel limited in their abilities to practice manual therapy, whether on their own or in the clinics that they are rotating into?
Okay. Well, as I've mentioned, I think number one, it will boil down to the competency of the clinical instructors because they still will guide the interns. So I really would highly suggest that the clinical instructor consider other types of treatment out there. Again, manual intervention, manipulation, mobilization has been in the RA 5680 of 1960 something. Sorry, I don't remember the year. So even at that point, like how did it even come to be in that definition, right?
Right,
So if we are very still limited in the usage of that, then that's something to think about because it does not only say modalities and exercise, it does say it clearly and explicitly on the definition, even if we follow that very old law. So I think CI should really look into that because they would be the one that would really control the learning of the interns. Now, with the interns, especially those with training, I really highly recommend that they really try to practice it, especially on the centers that really offer it or the centers that give them freedom. There are centers out there, like at least with our centers, wherein the students were given the freedom to do the treatment planning for their own patient, of course, with the approval of the CI. So then I would suggest that if they deem it necessary or indicated, then they should attempt to apply it. And I think I'm seeing a lot of that now. So that's why it would be interesting to look at like the responses of the students in the future. So number one, I guess like education, learning, lifelong learning. Number two, practice.
and finally, how do you hope your research will impact future PT practice and education in the Philippines?
Yeah, I really hope that the physios in the Philippines would consider the results of the study and because it really, really will kind of open up doors for us. And try to maybe bridge the gap of what they're doing in first world countries versus ours. Because if you look at our progress, I I calculated it. I calculated it that we're like 20 to 30 years behind because the treatment that we're doing right now is already what we were doing when I started in the United States back in 1995.
Mhm.
So we are a little bit 30 years behind first world countries, and for us to really and Filipinos are very intelligent people. We are like geckos. We really learn fast. And I really believe that. That's why whenever we go to the US, like give us like 1 year and we probably can get caught up in that 30-year span, right? Because I mean, I really truly believe that Filipinos are very, very much competent if they just put their mind to it. They're very intelligent. They will learn it if there is a push for it. That's why most Filipinos, again, after they go abroad, Europe, like Australia, I mean, in 1 or 2 years, they can blend in. Okay, I call it like a gecko. We're like geckos. So, but here, unfortunately, we have that culture that still holds us back. And the only way to kind of like get out of that is we get out of it ourselves. So we really need to speed up the process. Otherwise, we will continue to be 30 years behind our primary counterparts.
Thank you very much, Doc Lily, for that insightful conversation regarding your research and the implications of it, our discussions beyond it, education and clinical practice. I do hope our viewers or listeners of this podcast would grab the opportunity to read more of your research. It's found in the Philippine Journal of Physical Therapy. I will add the link to the research on the description of the podcast so that they may learn what this research is all about and what it can contribute to our practice. I'm not a manual therapist, but I do use manual therapy in my patients as long as I know that it's gonna help. So it's really trying to offer things to your patients that would really help them. And I like what you said, that how would you know if it's not going to help them if you didn't even try. So you know having those things, learning those things from internship to carrying it over to your practice would just really be helpful. So again, yeah, thank you, Doc Liddy, for that conversation. And if you'd like to dig deeper on our study today, I'm gonna post the link in the bio or in the description. So everyone, stay curious, stay inspired, and keep exploring the science behind our practice here with us at Behind the Research. Until next time, take care and keep on learning.